Good morning, everyone. For this next episode from TransConnect on blood component in pediatric patients, I am Dr. Mohit Chaudhary, a senior consultant in New Delhi, and this is April 2023. Now, this is a very important topic, especially because pediatric patients are the patients which are special patients. They are not just young adults, and you can extrapolate whatever you are doing in adults. So, therefore, they have unique requirement. They have unique emotional, social, technical, vascular, all those other technical difficulties. So you need to approach a pediatric patients differently. You should know the dosage of the blood that you are providing them, the components you are providing, and that is why you need to master it before you start venturing into this new world. So what we'll be discussing today is basics of blood components, just a brief about them, the individual components, the red cell, platelets, FFP, cryo, and grants, the pediatric dosage for the same, where we can use it, and some special situations where it is required and where we'll be using it. So out of the components of the blood, you can see that there is a cellular, plasma, and plasma derivatives. The cellular components can be platelets, it can be the red cells. Red cells are the most numerous. We have the plasma from which we prepare the FFP and the cryoprecipitate, and the plasma derivatives, from which we prepare the albumin, that is 5%, 20%, 25%, factor VIII, and coagulation factors. Importance of separation, of course, blood component separation is important. Why? Because of three main reasons. One is the optimum survival of each constituent. If you see in the whole blood, the platelets stay viable for just 1 day, and the labile coagulation factors like factor 5 and 8 decrease consequently. Whereas after separation, when you separate them into various blood components, the platelets stay up to 5 days, and the factor 5 and 8 can be stored as FFP for 1 year when they are stored at -30 degree or lower temperatures. So that is one use. Secondly, it avoids the use of unnecessary components which could be contraindicated in the patient. For example, if the hemoglobin is low, you tend to give packed red cell. If your PTINR is raised, you give FFP and not vice versa. Third point is by using blood components, several patients can be treated with the blood from one donor. So if one patient requires uh, red cells, that can be given from the same donor who has given his whole blood, and from his whole blood you can make out packed red cells, the platelets, and the plasma. Coming to the main topic where we are going to discuss the various blood components. First is the red blood cell transfusion. We all know whole blood is now a raw product. It is seldom used in big blood banks, and the only utility of which is to provide blood in cases of exchange transfusion, and that also we do it here or main blood centers by providing the reconstituted blood, which comprises of red cell, that is a packed red cell reconstituted with an AB plasma. So the main function of the whole blood is to provide oxygen carrying capacity, stable coagulation factors, and blood volume expansion, and it is generally used when there is a blood loss of greater than 25% volume. It is stored in triple bag or a quadruple bag when we take it, and depending upon which is 350 or 450 ml. And similarly, the anticoagulant solution ranges from 49 to 63 ml. It is 14 ml per 100 ml, so that's why in 350 ml bag it will be 49 ml, whereas in a 450 ml bag it will be 63 ml. The usual hematocrit is around 40%, and there is no component removed, and they are generally stored at 2 to 6 degrees Celsius. The shelf life of whole blood when you are storing in a CPD is 21 days, and CPDA is 35 days. Only when you increase the shelf life is by when you add an additive solution like SAGM or AS1, AS3, and AS5, it increases to 42 days. It increases the hemoglobin by 0.7 gram per deciliter, and the rate of transfusion is 3 ml per kg per hour. Packed red cell, if you see, it is prepared from the whole blood. The centrifugation is done, and the centrifuge bag is processed in an automated expressor. Packed red cell and plasma cell are separated, leaving behind the buffy coat, and generally when you do it by a buffy coat method, it is 1 log leucoreduce. An additive solution like an adsol or a sagam is added to the red cell, and a typical unit contains around 240 to 300 ml and a hematocrit of around 65 to 75%. These are the two methods of whole blood separation. So you can have a PRP method or a buffy coat method. PRP method essentially means there is a light spin followed by a hard spin. That is, the light spin is the lower spin or the lighter spin, and followed by a hard spin. So this will cause a formation of light spin, will lead to a formation of PRP, from which later platelets and plasma can be separated. On the other hand, Buffy code method, you start with a hard spin, that is the uh, greater centrifugation force, followed by a light spin. In this hard spin, you can, of course, there'll be a Buffy code formation, and from Buffy code you can derive platelets. The red cell and the plasma goes in the first spin itself. Which is better? We all know Buffy code method is a good method of separation, and essentially because it also provides 1 log leukoreduction. Coming to the indications, the component of choice for virtually all patients with a deficit of oxygen carrying capacity, that is example, blood loss or anemia. So whenever there is acute blood loss of greater than 25% blood volume, obviously red cells is indicated. The usual volume that we can calculate it through a Nagler's formula where it comprises of height and weight, or you can do some approximation studies wherein male blood volume is generally considered as 70 ml per kg. That means for a 70 kg male, it will be around 5 liters. For females, the blood volume is approximately 66 ml per kg. In children, which is the today's topic, you can see that premature infants are generally 100 ml per kg, and as a dictum, full-term infant is around 85 ml per kg. So what are the contraindications of red blood cells? It should not be used when there are specific medications available, like when you have hematinics like iron, B12, folic acid, erythropoietin are available, or if there is specific deficiency of iron or B12, where the patient is stable and does not require blood, so then you have to manage it with these hematinics. Or it should not be used for volume replacement at all. Coming to leucodepletion, very important. This is the process of by which the leukocytes are removed from the donated blood. They are the offending agent. They are the ones who cause most of the problems that are associated with the red cells, like FNHTR or the febrile non-hemolytic transfusion reaction, CMV transfusion, etc., etc. So what the quality control says is it is removal of at least 70% of the leukocyte with a loss of less than 20% of the RBC. So we all know that the average content of leukocyte in a whole blood is around 2 to 3 into 10 raised to power 9. So now this 10 raised to power 9 per 450 ml is the figure that we should remember. So the usual load of leukoreduction to prevent FNHTR or febrile non-hemolytic transfusion reaction is when you make it 10 raised to power 8. And this is known as 1 log leukoreduction, or from 10 raised to power 9 to 10 raised to power 8. And the critical leukocytic antigenic load is what it is. So when you do a 1 log leukoreduction from 10 raised to power 9 to 10 raised to power 8, it is called as critical antigenic leukocytic load, and this is achieved just by removing the Buffy code or preparing the blood components through Buffy code method. The other thing is when you actually reduce it to 10 raised to power 6. So once it was 10 raised to power 9 and you have done some filtration and you have leuco reduced filter available and it reduces to 10 raised to power 6. When you do that, it prevents the HLA allominization. Now 10 raised to power 6 means 3 log leukoreduction or more, and this is called as critical immunogenic leukocytic load. The earlier one, when you do 1 log leukoreduction, is critical antigenic leukocytic load, and the one in which you provide 3 log leukoreduction to prevent HLA allominization and transmission of lymphocytic virus like CMV, it is known as critical immunogenic leukocytic load. Sorry. So coming to when do you label it as leukoreduction? Leukoreduction is defined when residual leukocyte count is less than 5 into 10 raised to power 6 per container, that is the bag. So once you have that, you can label it safely as a leukodepleted product. The European guidelines are more stringent and they actually believe that it should be less than 1 into 10 raised to power 6. Our Drug and Cosmetic Act says that we should have leukocyte count less than 5 into 10 raised to power 6. So this is approximate residual leukocyte count in cellular blood components. You can see the whole blood is 10 raised to power 9. When you do a Buffy code preparation, there is 1 log leukoreduction. And when you actually go for a filtration or leukoreduction per se, then it is 3 log leukoreduction or 10 raised to power 6. So what are the indications? Obviously you are preventing FNHTR by 1 log leukoreduction. You prevent HLA allominization and prevention of lymphotropic virus like CMV, EBV, and HTLV when you do a 3 log leukoreduction. Coming to another modification, that is irradiation of red blood cell. You have to use gamma radiation to kill immunocompetent T lymphocyte, which are the offending agents here, and they can cause what is called as graft versus host disease. Why? Because the patient in which these are transfused, it is already immunocompromised. They cannot mount an antibody response, and these T cells are very immunocompetent, and they can cause damage to the host, and this is known as graft versus host reaction. To prevent it, you need to irradiate the red blood cell, and the dose that you have to give is 25 gray, and that has to be in the center of the bag. So in the center, it has to be 25 gray, and you have 50 gray outside. And how do you know that? You have some stickers, you have some indicators which you can put on the blood bag itself, and which changes color. So once you have the adequate dose, they will change color, and that is how you make out whether the cells have been irradiated or not. Indications include severely immunocompromised patient, lymphoma patients, stem cell marrow transplant, IUTs, neonates undergoing exchange transfusion, and Hodgkin disease. Of course, there are several other indications, like when you have near relatives giving the blood for you, that also you need to irradiate to prevent transfusion associated graft versus host disease. So the problem with the irradiation is that we already know that when you're storing the blood, one of the storage lesion is that the potassium increases, the intracellular potassium decreases, and there is hyperkalemia. So this potassium collects in the supernatant fluid and the closed store bag at a rate of about 1 milliequivalent per day. But when you do a gamma irradiation, it increases to around 1.5 milliequivalent per day. However, in usual cases, when there is no extra transfusion, the reinfused cells have normal in vivo survival. Nonetheless, the FDA regulation says, and the Drug and Cosmetic Act says, that the irradiated red blood cells should expire within 28 days or the expiry whichever is nearer. So once you have irradiation, your shelf life of the red cells decreases to around 28 days. Coming to the second topic, that is platelets. Platelets, we all know, are prepared from whole blood collected in anticoagulant solution, and a unit of platelet at least contains 5.5 into 10 raised to power 9 platelets suspended in 50 to 55 ml of plasma. So there is a considerable amount of plasma, and there is some trace amount of red cells. These platelets appear pink to salmon colored, and they can be obtained also by apheresis. So there is random donor platelets, which are a byproduct of the whole blood, and you have apheresis product or the jumbo pack or a single donor platelets, which are used in special conditions. Indications are very important for treatment of patients with bleeding, whether it is a prophylactic indication or thrombocytopenia, where the platelet count are actually low. You can provide platelets. This can be given as a treatment of bleeding patient in dilutional thrombocytopenia sometimes, and also many a times prophylactically and in post-operative bleeding. The contraindications are TTP. You never give TTP platelets because it adds fuels to the fire, and in heparin-induced thrombocytopenia, also in ITP cases, unless the patient has a life-threatening hemorrhage. The dose for an adult is generally 4 to 6 units, and it is one adult therapeutic dose is one single donor of platelets. A single unit may be sufficient for transfusion to neonates and infant, and that is why children weighing less than 15 kg, you give 10 to 20 ml per kg, almost like 10 ml per kg, and children weighing more than 15 kg, you can give 1 unit of SG. You can prepare it from apheresis, and it is leuco-reduced when you do that. There is advantages. It is a single donor exposure, and it may improve clinical outcome in patients that are refractory, essentially because there is only a single donor exposure. We have availability of PAS suspended platelets, which are just the platelets which are suspended in the electrolyte solution or a crystalloid nutrient media, which is used in place of the plasma in platelet storage. Now this overcomes the risk of AHTR, the acute hemolytic transfusion reaction, the allergic reaction, and also increases the shelf life of the platelets from 5 to 7 days. But since we are governed by the Drug and Cosmetic Act, and we have to stick to the 5 days shelf life of the platelets. So what are these electrolytes? You have the sodium, you have chloride, you have acetate, phosphate, citrate, magnesium, and potassium. So what they do is they all have different roles and the different formulation, but generally it is to maintain the pH buffer, prevention of coagulation or platelet activation, because then once the platelets are activated, obviously then they cause aggregation. So PAS suspended platelets are generally 70:30 ratio. You suspend the PAS solution, and that helps. How? Then your plasma is gone, and whatever the problems associated with the plasma are also gone. So selection of platelets, it is prudent to use ABO match platelet wherever possible. But whenever there is a delay in transfusion, you need to switch to the different groups, and especially when you have PAS product, you can give it across the group. Matching for D is very important. The platelets may contain 0.5 ml of RBC contamination when it is RDP, or a 5 ml, almost 5 ml contamination of RBC when it is single donor platelets, because the volume is more. So it can cause aluminization, and that is why it is for D negative females of childbearing age group, it is desirable not to give platelets from D positive donors. Third product that we have is FFP, or fresh frozen plasma. So it is separated from whole blood and frozen within 8 hours of collection, and it can be prepared both from apheresis or from the whole blood, where it is a byproduct. When it is produced from the whole blood, it is around 220 to 250 ml, and when it is prepared by apheresis, it is around approximately 600 ml. It contains all normal concentration of coagulation factors, it contains fibrinogen, it contains labile coagulation factors, factor 5 and factor 8, and it is used as for plasma, has a volume expansion oncotic properties but should not be used for volume expansion. So transfusion is usual dose is 12 to 15 ml per kg, and the rate is 10 to 20 ml per kg per hour. The thing with the FFP is that you require it for thawing because they are in a frozen state, so you need to give some time to the transfusion medicine department for it to be thawed, and then only they can issue it. Coming to very important product, that is cryoprecipitate, which is underutilized I feel, but has a wide variety of indications. It contains factor 8, factor 13, fibrinogen, fibrinectin, and von Willebrand factor, and is essentially used in cases of when there is a fibrinogen defect or a factor 13 deficiency. So how is it prepared? It is prepared by thawing FFP at a temperature between 1 to 6 degrees Celsius. After centrifugation, the supernatant plasma is removed and the insoluble cryoprecipitate is refilled. So each unit contains mainly 80 international units or more of factor 8. So it can be used in cases of hemophilia when factor 8 concentrates are not available, and at least 150 milligram of fibrinogen if your quality control is in place. So 150 milligram of fibrinogen and 80 international unit of factor 8. Also, it contains fibronectin, it contains factor 13, and it contains von Willebrand factor. What is the function? Its main indication is the source of fibrinogen or factor 13. Transfusion is say average volume is around 15 to 20 ml. So the usual dose, pediatric dose is 5 to 10 ml per kg. It also requires 30 minutes notice for thawing. So 5 to 10 ml or 10 to 15 ml per kg is the usual dose. Another dictum that the pediatricians generally follow is that they give 1 unit per kg. So this is the cryoprecipitate, unit of cryoprecipitate, which can be used as a solo case, or you can, because the adequate dose in adults is generally 10 units, so you need to pool them. So you can have 2 packs of 5 units, which can be called as pooled cryo. Very important, granulocyte transfusion is another uh, thing that we have in our blood bank, and this is considered for septic and neutropenic neonates. The characteristic include it is stored at room temperature without agitation, unlike platelets, and should be transfused as soon as possible after collection within 24 hours, preferably within 6 hours. Must be ABO compatible because each unit has a large amount of WBCs, and the maximum that you can take is 500 ml as per quality control, and should contain at least 3 into 10 raised to power 11 WBCs or grams. The characteristic with the donor that you need to do is that you need to call the donor, check for the vein 1 day prior, and also give a dose of GCSF and dexamethasone 12 hours before the procedure, 8 to 12 hours before the procedure. Coming to the pediatric transfusion guidelines, when I say pediatric, we are not covering the neonates, and in neonates, if you see in the pediatric age group, they are taken almost up to 4 months. So anybody who is more than infants greater than 4 months of age and children up to the age of 18 years is what we are going to discuss. What we are not going to discuss is the neonatal period where or neonatal alloimmune thrombocytopenia or HDFN. So it is going to be strictly infants greater than 4 months of age and children up to 18 years. So coming to packed red cell, the principles that apply to adults applies to pediatric. When it comes to packed red cell, the clinical assessment is imperative. So you need to check clinically whether you require red cells or not. For a non-bleeding stable patient, the restrictive regimen is followed, and which says that instead of HB 9.5, HB 7 is the transfusion trigger. So if a stable patient is there, you should not transfuse if the HB is greater than 7 gram per deciliter. And this includes ICU patients and operating room patient. However, if patient is unstable or there is symptomatic anemia, you can consider higher HB trigger. For oncology patient, there is no specific evidence, but you can increase the transfusion trigger or HB trigger to around 8 gram per deciliter. For disorders of red blood cell production and hemoglobinopathy, obviously you need to consult a specialist. But generally for hemoglobinopathy like thalassemia, the threshold or the threshold that we keep is generally 9 to 9.5, and we want the HB to remain at that level. For disorders of other red cell production like congenital dyserythropoietic anemia, pyruvate kinase deficiency, or Diamond-Blackfan syndrome, we generally keep it around 8 gram per deciliter. So for bleeding patient, we maintain the hemoglobin greater than 8 gram per deciliter, and the transfusion guideline says that it should be 10 to 15 ml per kg up to 300 ml, which is 1 unit. So we anticipate after we give this dose of 10 to 15 ml per kg, increment should be around 2 gram per deciliter. For thalassemics, instead of 15 ml, we can go to thalassemics for 20 ml per kg. Now, once we start the transfusion, because thalassemics and these patients are multiply transfused, the first 15 minutes is very crucial, and that is why you need to go very slow. So we start for first 15 ml as 1 ml per kg per hour, and then we increase the dose when everything is going normal. For platelets, if you see, the indications are variable, and also platelets are less predictable when it comes to bleeding. So that is why the thresholds have to be, they can be variable and they can be liberal. So you have to know that for prophylactically less than 10,000, you should give platelets. And depending upon the other platelet counts, you should have a chart ready for yourself. You can use this chart wherein each platelet count will signify when to start the platelets. At the same time, clinical judgment is imperative, and if you feel that the platelet count, even though it is little higher, but you feel that the platelet needs to be given, you should not stop the platelet. The usual dose for platelets is 10 to 15 ml per kg, or generally 10 ml per kg, up to one adult dose you can give. And the rate of transfusion for the first 15 minutes is 1 ml per kg per hour, and this applies to all the blood components. So first you need to see for the first 15 minutes, and when the things are okay, you can increase the usual rate to 10 to 20 ml per kg per hour. The thing that you should remember is platelets should not be transfused from a previous used tubing set or the BT set which is used for packed red cell, because they may contain fibrin and they may capture the platelets, and this may erroneously not give platelets to the patient. They have a shelf life of 5 days, of course. Now coming to plasma. Plasma, the most common indication is when there is massive transfusion or a significant bleeding, or if your PTINR is raised. So once your PTINR is less than 1.8 and patient is stable and not bleeding, you do not require that plasma should be given. If it is between 1.5 to 1.8, then you need to see specific conditions in which you need to give plasma. Now dose is 10 to 15 ml per kg, and one dose raises the coagulation factor levels by about 20%. Like all blood components, for the first 15 minutes, you monitor them, give it as a loading dose of 1 ml per kg per hour, and then the usual rate to 10 to 20 ml per kg per hour. Very important, cryoprecipitate. It contains all these factors, that is fibrinogen, factor 8, 13, 1-vanilla factor, and fibronectin. The dose for children who weigh up to 15 kg is 5 to 10 ml per kg. The usual dictum is you can give 1 unit per kg also. For weight over 15 kg, you can give an adult therapeutic dose, that is 2 packs of 5 unit or maximum 10 units. For first 15 ml, it is 1 ml per kg per hour, and usual rate is 10 to 20 ml per kg per hour. There are special situations such as in PICU or the pediatric ICU. The the randomized control trial suggests that the restrictive HB transfusion threshold, that is 7 gram per deciliter, are safe, and it is in clinically stable neonates requiring small volumes of top-up transfusion. So a restrictive red cell transfusion policy is safe for clinically stable children on PICU. However, if the children have symptomatic anemia or impaired cardiorespiratory function, a higher threshold for the child may be sought. For hematong patient also, the transfusion trigger of 7 gram per deciliter is appropriate. but the guideline needs to be followed, and wherever it is patient is sick or there is a sick neonate and the relationship of thrombocytopenia to serious bleeding and appropriate trigger remains uncertain, you need to give platelets, and that's why a more liberal platelet prophylaxis policy may be justified. Now, major hemorrhage protocol or major transfusion protocols are also being followed in the pediatric patients, and this has to be followed not in units but in ml. So the usual ratio is 2:1:1 or 1:1:1, where it is plasma is to red cell is to platelets, but you need to manage it with ml, that is mils, but not according to the units. Age-specific blood components should be used as long as urgent provision of blood is not delayed. And nowadays, like you give in trauma-induced coagulopathy in massive hemorrhage, tranexamic acid upfront, you need to give the same in case of pediatric trauma hemorrhage as well. So to conclude, blood transfusion is not without hazards. We have to weigh the risk against benefit, use the right product to the right patient at the right time. Policies need to be followed. Training and education for the hospital staff should be considered. Use of special product is must for specific patient in pediatric age group. And not, last but not the least, complications of transfusion must be avoided. The rate of blood exposure should be reduced and safety of transfused agents or components should be maintained. And this must be kept in mind always before you are undergoing this therapy of blood components. Thank you so much. I hope this was helpful to you. And if there are any questions, I'll be happy to answer. Thank you so much.